the topic of intracranial infection that we have finished the first part of it yesterday. Then we'll continue with, I hope you remember that we finished the congenital intracranial infection, the infection with viruses known as encephalitis, infection with bacteria known as cerebritis, and the infection of the meninges known as meningitis. ممكن نطفي النور عندي الشاشة. Now we'll continue the series of these inflammatory lesions, and we are going to discuss now the tuberculous infection. And you know that TB is one of the prevalent types of infection in our area, and the clinical picture of TB intracranial infection will include fever, headache, vomiting, and sometimes the cranial nerve affection, maybe seizures, and sometimes the infection will spread in every direction, like reaching the brain parenchyma and reaching the ventricles, may be resulting in inflammation of the choroid plexus, which is known as choroid plexitis. TB is an infection that is increasing in the our area, and it is even prevalent in immune competent patients, and these are the supposed risk factors, which include alcoholism and diabetes, immunosuppression, and of course HIV and infection. Tubercle bacilli will reach the brain or the central nervous system, will result in TB granulomas, which are known as tuberculomas. These tuberculomas may proceed to form TB abscesses, and the infection of the brain parenchyma may result in focal cerebritis, and also the presence of inflammatory granulation tissue in the basal cisterns will affect the vessels, including the arteries and veins. The three common sites of affection for any organism will include the meninges, the brain parenchyma, and the ventricle. Affection of the meninges will result in TB meningitis, and this will appear on imaging as meningeal enhancement. Meningeal enhancement will affect the absorption of the CSF space in the subarachnoid, or the CSF in the subarachnoid space, leading to communicating obstructive hydrocephalus, and vascular affection will result in ischemic changes in the brain parenchyma. Yes, as you can see here, we have this is the pre-contrast T1 weighted image and the post-contrast scan, and you can easily appreciate the enhancement in the basal cisterns, as well as the sylvian cistern, as well as the quadrigeminal cistern, what is known as leptomeningitis. And of course, a common association is the distension of the temporal horns of the ventricles, denoting the presence of hydrocephalus. Then the basal meninges affected by TB will show this prominent pattern of enhancement. And actually, in Egypt, for example, whenever we see meningitis, we usually assume that TB is the underlying pathology. Of course, the leptomeninges are affected, but the brachymeninges also may be affected. Then extension of the inflammation to the ventricular wall will result in ventriculitis or ependymitis. And the common complications include the development of hydrocephalus and the presence of vascular affection leading to ischemic changes in the brain parenchyma. And this is an example. This is the diffusion weighted image, and this is a T1 post contrast. And also, this is a T1 post contrast. You can see enhancement of the leptomeninges, and you can appreciate the presence of abnormal signal in the basal ganglia and the internal capsule, and these areas will show diffusion restriction, meaning that they are acute insults, and they are the sequelae of vasculitis secondary to vascular compromise. And here you can see the MR angiogram showing the marked attenuation of the A1 segment of the anterior cerebral artery on the left side, while the MR venogram shows normal findings. Another example, this is a pre-contrast scan and a post-contrast showing distension of the temporal lobes, meaning hydrocephalus, enhancement of the basal cisterns and cerebellar folia, meaning leptomeningitis, and a small focus in the right thalamic area. And this focus and others showed diffusion restriction, meaning that they are acute ischemic foci. The development of granuloma in the brain parenchyma has three types, and this is known as the tuberculomas. We have a non-caseating tuberculoma, which will appear of low signal in the T1 and high signal in the T2. It will show homogeneous contrast enhancement with no diffusion restriction. And the smaller one are best examples for this non-caseating tuberculoma. Then the second type is the caseating tuberculoma with a solid center, and at that time the tuberculoma will appear of intermediate signal in the T1 and T2 weighted images, but the periphery of the tuberculoma will show some hyperintensity in the T2. If you inject contrast material, it will show marginal enhancement, but this will not show diffusion restriction. And in this stage, it is likely that these lesions may be mistaken for metastatic deposits. As you know, that metastasis will not show diffusion restriction. And this is an example of a non-caseating tuberculoma, which is a very big one. You see the core of the lesion is relatively hyperdense in the CT scan due to the presence of caseous material. If you inject the contrast material, the margin will enhance. If you have the diffusion weighted images and ADC, you will see no evidence of diffusion restriction. The third type is caseating tuberculoma with liquefied center, and this is exactly similar to any brain abscess. The abscess will appear hypointense on the T1, hyperintense on the T2, with hypointense rim, as I have mentioned yesterday. This rim is very characteristic of an abscess, and it's quite clear in the T2 weighted image because it is surrounded by high signal intensity of pus inside the abscess and high signal intensity of edema outside the abscess. And this stage of tuberculoma will show diffusion restriction, and you cannot easily or you cannot discriminate this tuberculoma from any abscess in the brain parenchyma. Then that's why you may be confronted by TB lesions in the brain. Some of them show homogeneous enhancement with no diffusion restriction. Some of them will show marginal enhancement with no diffusion restriction, and others will show marginal enhancement with restricted diffusion, and this is known as tuberculous abscess. Of course, at the time, as I have mentioned, in the tuberculoma with non-liquefied center, it will show no diffusion restriction, and this may be mistaken for a glioma or metastatic deposit. Then the best way, of course, the best way is to go for the clinical data, which are very important in reaching the real diagnosis. And if the clinical data are not conclusive, then you may need the help of a spectroscopy. And you remember that if this is a neoplasm, you will see marked elevation of the choline peak and some depression of NAA peak. But here you see the generalized depression of all the metabolites except the lipids and the lactate, which are present in this type of infection or in abscesses in general in a high level. And then the next type of granulomatous affection is the sarcoid. And the sarcoid is a multi-system inflammatory disease. Its etiology is unknown. And this sarcoid will affect the meninges and the brain parenchyma, similar to any other type of infection. The CNS involvement in patients with sarcoid is about 5%, and about 90% of patients with sarcoid, neurosarcoid, will have pulmonary involvement, which can be of help in the differential diagnosis. You need the clinical history, and you will see leptomeningeal enhancement, which is one of the prominent features of sarcoid, and other imaging findings, especially in the chest. You got lymphadenopathy in the mediastinum, and you got interstitial opacities and nodular lesions in the lung. Then if you look here and you see affection of the dura, what we call pachymeningitis, diffuse thickening and enhancement of the meninges. And this appearance is not characteristic for sarcoid, but it includes a list of differential diagnoses, and the sarcoid is one of them. You may think of another type of meningitis or metastatic disease, or maybe if this localized form, you think of a meningioma sometimes. Then one of the best sites for neurosarcoid is the pituitary gland, and especially the infundibular stalk, as well as the suprasellar area. And you got some swelling of the pituitary gland, thickening and enhancement of the stalk, and enhancement in the region of the hypothalamus. Also, one of the manifestations of sarcoid, which is not that frequent in the clinical practice, is the presence of plaque-like mass of meningeal thickening, which is known as pachymeningeal involvement. And this lesion is sometimes difficult to be differentiated from meningioma and lymphoma. Here you see the lesion is of low signal in the T1 and of extreme low signal in the T2 and homogeneous post-contrast enhancement. Then we came to involvement of the CNS by fungi, and there are a lot of fungal organisms that can reach the brain. Fungus, of course, has an intimate relation to the immunity and is relatively common in patients who are immune suppressed. like those with HIV, the cancer, those with neutropenia, organ transplant, or prolonged corticosteroid use. Sometimes in fungal infection you got fever, but this is not usually the case. You got headache, you got seizures, and of course some neurological deficits. Fungus, if it reached the brain, will result in fungal abscess or abscesses, or infection of the brain parenchyma may occur as patchy, homogeneously enhancing lesions without the formation of abscesses, or sometimes common, especially in Sudan and in Egypt also. You got intracranial fungus infection coming from the fungal affection of the paranasal sinuses. It's very important to know that the fungal abscess will not show diffusion restriction. In the CT scan, you can see there is a classic appearance of an abscess with surrounding perifocal brain edema exerting a massive effect. On the MRI, diffusion weighted image, and ADC, you see many observations. Number one, the wall of the abscess show restricted diffusion. Number two, there are projections inside the abscess showing restricted diffusion, and these projections are not seen in ordinary images. It is only seen in diffusion weighted image. And the core of the abscess, the content of the abscess, do not show diffusion restriction. It appears low signal in the diffusion weighted image and high signal in the EDC map. Then here you can see an example of multiple fungal abscesses in the brain. This is T1 and this is T2. This is T1 post contrast. This is diffusion and this is EDC. Of course, whenever you are confronted by a case suspected to be an inflammatory affection of the brain, and you may think of TB or fungus, then you may have different findings that are not expected to be seen in the diffusion weighted images. If the clinical data are not helpful, you may need the help of MR spectroscopy. One of the prominent features of fungus of the brain parenchyma without the formation of abscesses is this appearance. And you look in the T1 weighted image, you see a lesion which is of intermediate signal. And the T2 weighted image, you see very dark appearance of the lesions. And many of you may interpret this as an acute intracerebral hematomas, because the hematoma will appear of intermediate signal in the T1 and dark signal in the T2 weighted image. But if you inject the patient with contrast material, hematoma of course will not enhance, but fungus will strongly enhances with contrast material, as you can see here. As I have mentioned yesterday, you should not interpret any of the imaging procedures without the presence of full clinical data about the patient. But many times in our practice and our exams, the history is lacking. Then you depend on your capabilities to make use of the different findings on imaging, and this is one of them. Then if you look here, and you see an infiltrative lesion in the left cerebral hemisphere that turned bright in the FLAIR image, and after injection of contrast, you got that patchy, strong enhancement. This appearance is not usual for any type of the gliomas, but it can be seen in lymphoma, for example. Then whenever the history is lacking and the previous films are not helpful, then in order to reach that this is a fungal infection, you may need the help of MR spectroscopy. Lymphoma is one of the differentiating points here, and metastasis, although this is not usual for metastasis, metastasis may show a necrotic center and a significant perifocal brain edema. The next is زي عندنا بالظبط حتى بس بدأت أشوف